So Dr. Cortes is the Director of Neuromodulation at the Rehabilitation and Human Performance Department at Mount Sinai. She's a physical medicine and rehabilitation physician and neuroscientist focused on understanding neural plasticity and its implications, as well as developing novel, individualized rehabilitation strategies to promote recovery and improve quality of life for patients with neurological impairment. Dr. Cortes, you have the floor.
Thank you very much, Amanda, for the very kind introduction. And well, I'm very happy to be here. As Amanda can say, I'm a PM&R doctor who had a very an inquiry about how we can do better in rehabilitation. When I was a resident, I realized that there were not many treatments for neurological disorders. Neurorehab was my major interest, and I really wanted to understand better how we could improve either the current approaches that they were available for patients, and also how we can create new tools to improve the quality of life of our patients with neurological disabilities. So I joined the Abilities Research Center here in the rehab department 4 years ago, and the mission and the values of the center, they were very much aligned with minds, right? We're trying to cure neurological disabilities through research. I think that this, I just divided it in three folds. My main interest is to try to understand neural plasticity, how the brain works in health and also after neurological damage. I'm interested in developing these novel strategies for addressing the consequences of neurological injury, not only in the motor aspect of it, but also the sensory, psychosocial, etc., looking at the patient as a complete kind of individual. And also, we're interested in rapidly accelerate the path of these novel technologies from the beginning, from the scientific concept, from the idea to the mainstream clinical adoptions by taking these technologies that we have vetted and just doing clinical trials on them. So the idea is always to create scientific knowledge, implement this knowledge in rehabilitation practice, and pass all of this in education and training for the future generations. So I'm going to be talking today about neuromodulation and neurorehabilitation. And the objective of this talk is going to be to understand first what are the principles of neurorehabilitation, what is neuroplasticity, and also what are the neuromodulation techniques that they are available, the non-invasive neuromodulation techniques available, and how we can use them, or they can be used in neurorehabilitation. Okay. So let's get started. Neuroplasticity is believed to be the basis of recovery after an injury to the central nervous system. Carmichael said that in this beautiful paper that I suggest all of you to read, that it's harnessing neuroplasticity for clinical applications. He describes neuroplasticity as the ability of the nervous system to respond to intrinsic or extrinsic stimuli by reorganizing its structure, function, and connections. This can be triggered by an injury, but also by an activity or training. So we know that active training enhances neuroplasticity and results in reorganization of the cortical maps. No rehabilitation does not result in that reorganization. So rehabilitation, it's mandatory, and to create this change, this reorganization of the cortical excitability, of the cortical reorganization, that it's what it's been associated with an improved function in patients. These neuroplastic changes after injury, they take care, these changes take place after the injury. There are many of them, and they are listed here. They go from an increase in the number of synapses, changes in the dendrites, changes in the axons, increasing the number of neurons, formation of new blood vessels, and changes in excitability of neurons, such as the ability to generate action potential. So when talking about neuroplasticity and how that can influence our patients' quality of life, we need to take into account what are the quality of life domains. And I always like to put this up because often when we talk about rehabilitation, we think about the physical consequences of an injury, but we need to think a little bit more broad in the sense of thinking about this psychological, the level of independence, the social relationships, environmental health, and the spirituality when talking about quality of life. So let's start talking about what is neuromodulation. Neuromodulation has been around for a very, very, very long time. And it has passed from the scientific knowledge to the general knowledge, creating currents that change the way that brain it works. It's something that it has been told for years and years now. So what is neuromodulation can be non-invasive or invasive. I'm just going to talk only about non-invasive brain stimulation. So what is non-invasive brain stimulation? It's a painless and safe technique that it has minimal side effects, and it has been used in thousands of people worldwide to modulate the brain activity. What it aims is to improve quality of life and reduce the effects of issues related to different things, such as speaking, swallowing, movement, cognition, etc. All of this can be achieved by stimulating the damaged area of the brain to help restore the affected function, or stimulating a different area of the brain to compensate the loss of function. So in this big schematic, you can see the different types of non-invasive brain stimulation. We're going to divide them into sites: the transcranial magnetic stimulation and the transcranial electrical stimulation, with the TDCS being the most famous one. We have also transcranial alternating current stimulation and the transcranial random noise stimulation. These two, they have come out a little bit later in the past, probably 10 years or so, and they are gaining more and more success. But everything is like kind of under review. So TMS, transcranial magnetic stimulation, can be elicited as a single pulse, per pulse, repetitively, of pattern, that it's called the RTMS. So RTMS is a non-invasive FDA clear medical procedure that it has been cleared for depression and some cases of schizophrenia. It's this technique that relies on the generation of a brief magnetic field using this insulated coil that is placed over the scalp of the person. These magnetic fields that are the same type of strength of those used in MRIs machines, and they generate like a weak electrical current in the brain that briefly activates neural circuits at the stimulation site. RTMS can be shown that to be safe, it's well tolerated, and can be very effective in treatment for patients with neurological and also psychiatric disorders. And the same happened with transcranial electrical stimulation. So they have some differences. TMS is very versatile method that modulates, as I said, this neural processing in the brain by inducing that a short capacitor discharge of this electric current into the stimulated coil and generating this magnetic field, which then induces the neural cell membrane potential to depolarize. Okay. On the other hand, the TDCS, that is this very famous form of TES, transcranial electrical stimulation, modulates the neural activity in the brain. From a physiological perspective, TDCS affects brain function in two ways. One is by altering the baseline activity level of targeted neurons and by modifying the functioning at synapses. The effect of neuron activity levels always occur while you are zapping, and the synaptic influence, it has like a long-lasting effect. The reason why TDCS in the last years had so much success and has been trialed in so many different clinical trials is because it's portable, it's easy to use, and it's very cheap, and it can be used at a home setting. What TMS, it's a device that requires training. It's a little more complicated to use, and it's much more expensive. Here I also wanted just to let you know that the different types of transcranial electrical stimulation, they has different effects. They affect different, they have different neural effect, and it all depends in the type of current that they have. Okay. In my career, I have only used transcranial direct current stimulation. Now it's going to be the first time that we are using transcranial alternating current stimulation in a clinical trial that we just started, using this kind of stimulation with language training for patients with aphasia after a stroke. Very, very exciting. So neuromodulation is like a very rapidly growing field, and TMS has been around since 1985, and the number of clinical trials that they are published per year, they continue to grow. The same happened with TDCS that was around in the 2000s, and the last two, they have been around, as I was saying, well, it's 2000 and maybe 7, 10, something like that, the last 10, 15 years. But again, it's a field that continues growing. Here is a schematic of how TMS works. When we do repetitive TMS, we just put this coil in the top of the skull of the person. We can be using neuronavigation, and we will know exactly by changing the movement of the coil on top of the skull on where is that we are stimulating. Okay. The stimulation is always very personalized, meaning that we will be adjusting the resting motor threshold, so the minimum intensity that we will need to elicit a response from that stimulation for each patient. I'm going to show you an example in case that you're not familiar with what TMS is. So this is a postdoc in I teach in a fellowship at Harvard Medical School about transcranial magnetic stimulation. So this is one of the postdocs that that wanted to volunteer for experiments just to show how TMS works. So this is the coil that it's placed over the M1 area over the primary motor cortex. We are targeting that that subject's hand, and here is the images from the neuronavigation device, right? Telling us exactly where it is that we are stimulating, looking at the different planes. So what we see, let me see if I can put this on.
We've identified, we're also going to just adjust our angle. I've noticed that maybe my approach angles based on the bottom right images, the oblique images were not quite optimal. Oops, there we go.
You have a muscle twitch.
Good, see, we're basically hitting to within a couple of millimeters the same target, but by simply adjusting the approach angles of the coil.
By simply adjusting the coil, we can target different areas. It's very, very precise. That's why TMS has been used for many, many different reasons. And we're going to go into that in a second. So as I was saying, the TMS is placed in the motor cortex, it stimulates the corticospinal tract, and with surface electrodes, we can just calculate the motor evoked potential. That is this biphasic wave where we can just measure a few things such as latency, the peak-to-peak amplitude, etc., etc. So we can compare all of this within subjects and also within different neurological disorders. So why to use TMS? So we can select assessment tools that investigate either function or biology, right? It's with its own merit, depending on the question that we are being asked, the research question, depending on the required sensitivity, reliability, and functional relevance. So brain stimulation has been previously used because it relates to function, but also provides important detail about the mechanism. Functional scales, for example, as the gold standard regarding the clinical relevance, but they have very serious limitations about movement characteristics, for example, if we are talking about motor recovery, as well as having limited sensitivity, especially for single training sessions, right? What are very important to inform, for example, large clinical trials. Sensitive kinematics and kinetic measures, for example, that they're given by robotics, they are excellent outcomes solving all these problems. They are extremely sensitive and provide insight into the characteristics of movement that underlie that clinical dysfunction. So depending of the question that we want to ask, and if you are more interested about knowing about the function of the biology of the problem that we have in front of us, we will be using like different scales. And TMS really is like kind of in the middle of all of them. So TMS can be used in two folds for two different things. One, as a primary clinical application, it can be used as a diagnostic biomarker, using it as a single and pair pulses. I'm not gonna go into a lot of the physiology of it. It's really fascinating, the physiology of the brain and the spinal cord. But just know that there are many different measures of cortical excitability, motor threshold, cortical silent period, short and long interval cortical inhibition, that they tell us a lot about the area that we are exploring and also what are the differences or the connections between the two hemispheres. And that it can give us an idea of what is the current physiological moment in which that disease is. And also, if we do longitudinal studies, it can give us an idea of progression or not, what is very interesting. But TMS can also be used as a neuromodulatory treatment. So when applied repetitively, it can have either an excitatory or an inhibitory effect in the cortical excitability. Okay, depending if we use high frequency or intermittent theraburst stimulation or low frequency or continuous theraburst stimulation. So here we have listed like all the TMS parameters that they can measure cortical plasticity, and it has been studied which of these are related with what kind of receptors, etc., etc. It's all very interesting if you want to go deep into what are the mechanisms of certain disorders, for example. So brain stimulation has been used, sorry, I cannot pass this. See? There we go. For example, one of the biggest use of brain stimulation has been in stroke rehabilitation. Brain stimulation as a neuromodulatory technique has never been used by itself. It's always used in addition to physical therapy, occupational therapy, or any kind of therapy that they are targeting whatever is that we are either exciting or inhibiting in that brain. In the stroke, we know that the affected hemisphere usually has a decreased excitability, and the unaffected hemisphere had increased excitability. That's why they are used all of these different inhibitory or excitatory techniques in one side or another side of the hemispheres. There are many different papers, and there's a big scientific knowledge now about what is the neurophysiological characterization of all of these neurological disorders by using TMS, right? So we have all the different TMS measurements here: motor excitability, interhemispheric conduction, silent period, MEPs, etc., depending if they are dispersed, or big, small, or absent. We know we can describe different neurological disorders, right? For example, spinal cord injury will have decreased MEPs, motor evoked potential, and larger latencies, conduction times, right? So you can just be describing this kind of disorders with this, just to learn about the mechanisms, as I was saying. However, we have a problem here with neurodegenerative disorders, right? There are many limitations because there are disorders that they're actively changing. But it is true that there are many recommendations from these kind of disorders. For example, the TMS should always, I say, be part of a multimodal approach. We will have like a TMS assessments with TMS and EEG, with neuroimaging, etc., etc. TMS also in these kind of disorders should track longitudinal changes, and it can be tracked before the symptoms appear, pre-symptomatic, and then in the manifest stages of the disease, where it gives you a lot of information of where the disease goes. It's important also the investigation of specific symptoms that they should be assessed when these symptoms are present. Because if they are not present, probably the neurophysiology is going to change to a more normality. I do normality, with brackets because I don't like to the word normal. Nothing is really normal, but the normal parameters are always like a range of what the majority of a healthy brain will have. So this is what TMS give us, and this is what TMS tell us. However, and we do have in the department a TMS device, and we are doing a lot of studies with it. However, we also have transcranial direct current stimulation, TDCS. Okay, this is a totally different kind of neuromodulation approach that it just passes very small current from the anodal stimulator to the cathodal stimulator, and we will be placing those in different parts of the brain according to what is that we want to do in that brain, and according to what is the previous pathophysiology of that disorder, right? Like I explained just with that happened with a stroke. So this is the StarStim device, the neuroelectric device that allow us not only to change the excitability of the brain, but also to measure the EEG signaling. We are able to do electroencephalography and see how the brain changes before, during, and after any kind of TDCS information. I really like TDCS because it's really like very effective. It's cost efficient. It costs so much less than TMS. It's time efficient. Usually you only need 20 minutes of putting like this hat in the patient's head. The patient can go and move around because everything goes through Bluetooth, and it's very accessible because you can access everything from your computer. Despite the fact that now there are like even new models that they allow you to control everything from home and to do home-based treatments. With everything, it's controlled the timing, the intensity, etc., etc. TDCS has been so advanced that now they are like modeling studies that show us when working with all these biomedical engineers that it's very interesting working with them because they tell us where that intensity of that current goes. So depending on where you put those anodal and cathodal stimulations, you can put them in the shoulder, you can put them in the neck to do spinal stimulation, etc., etc. You can check what is your optimal parameters and the optimal stimulation sites that we need to get like the maximum efficacy of that protocol. However, not all the brains are created equal, and there are many different individual differences in to transcranial electrical stimulation and its response, right? Sorry. So things like the stimulation intensity, of course, the electrode size, area, and shape. There are many different shapes. The stimulation location, the session repetition, how many sessions do we do, the spatial relationships with the targeted field, the genetic and polymorphisms of the patients, usually BAL-MET. It needs to be taken into account because it has been seen that it has differences in the effects of the responses and the stimulation duration. So just to make it a little more complicated, when we use TMS, TDCS, any kind of neuromodulatory approaches in combination with any kind of therapies, we need to take into account many different things. We need to take into account what is the single effect and also the combined effects, because it's not only like a sum of the both of them. Also, we need to take into account what is going to be the stimulation protocol for that person, what is the most, the optimal one, what is going to be the training regime, what is going to be the sequence of that stimulation, if we're going to have multifocal stimulation, because some neurological disorders, they don't have only one area of the brain affected. It's a more like a multifocal or combination of areas that the connectivity doesn't work correctly. We need to take into account the stimulation location and also the patient stratification. Taking, for example, the stroke example, we need to see if the stroke is cortical or subcortical, if it's in the acute or chronic phase, and if it has an impairment that is mild, moderate, or severe. So I don't know if I should just finish with this slide, because it really seems like complicated, but it's not that complicated. We just need to know what is the neurophysiology of the disorder we are studying, understand what the disbalance is, and try to balance it out with neuromodulation. Understanding the brain and understanding how plasticity works, it's mandatory to use these kind of techniques. And it's not the same to treat or to investigate a healthy brain as to investigate or treat an unhealthy and impaired brain. It's like treating animals and then doing the extrapolation of the results into humans. It's not as complicated as that, but we need to take into account that there are going to be differences. Just letting that over there. I love this slide. It's a little bit of a pity that exists because Kate Hoy, that it's an Australian scientist, and myself created this Women in Brain Stimulation database of female scientists working in brain stimulation to avoid discrimination bias in scientific conferences, to ensure gender representation and collaboration between female scientists. I just want to really put it out there, the importance to have mentors. There was a time where the first brain stimulation conference was held, and there were only 2 female scientists as speakers among 70 male speakers. And Kate and I, we were those 2. When we asked about this issue, we were told that they were not aware of other brilliant brain stimulation scientists. So that's why this Woman in Brain Stimulation database was created. So let's just change a little bit the rhythm about this. It goes with what we have been explaining about. We do have a neuromodulation program within the department. There is a neuromodulation program in the psychiatry department, and it's about everybody over there is treating psychiatric disorders such as depression, schizophrenia, etc., etc. That's the Helen Maber group. And then there is an invasive neuromodulation program also in neurosurgery with the brain stimulation. So the program that we have is is targeting different conditions such as chronic neuropathic pain, motor recovery, spasticity, dystonia, aphasia, tinnitus, and cognitive problems. The therapeutic value of brain stimulation has been recognized by a range of medical fields, and our program, it uses this non-invasive brain stimulation to help different brain functions. So the patients that we will be helping go from stroke, spinal cord injury, TBI, Alzheimer's, Parkinson, etc., etc. So as I said, TMS can be a great addition for diagnosis and prognosis of some neurological disorders, but also give us the opportunity to study the pathophysiology of a specific disease. And it allows you to monitor the progress of the disease or the injury during all the rehabilitation program. The way that we have to optimize brain stimulation is being very, very, very careful with subject selection and all the TMS or TDCS parameters such as intensity, location, timing, number of repetitions, etc., etc. So with this, I will finish the TMS and TDCS part, and I will jump to something that is also modulation. So and that really excites me because due to recent pandemic issues that we had in the past 2.5 years, mental health issues have arisen. And a lot of the mental health issues are happening in the healthcare workers. So David Petrino actually and Muriel Phillips got into creating or using biophilic design to see if bringing nature into the hospital, into very well designed rooms, I think I'll show you in a second, the mental health could improve. So we're taking this a step forward to see if these immersive experiences that the studio elsewhere creates can modulate brain activity, reduce stress, and improve mental health. So Studio Elsewhere, for those of you that are not aware, they are the pioneers of the bioexperiential design at Mount Sinai. They started at the ARC, creating the first recharge room, and now there are over 50 recharge rooms in the United States. So these immersive interactive environments simulate the healing experience of being in nature and can evaluate and treat health issues. So for some of you that maybe don't know these places, I invite you to come. We are running a study that I will talk about in a minute. These biophilic immersive experiences, they use lighting, sound, voice-activated experiences that you can choose, music, scent, and all of this is designed to reduce stress, okay? Stress, anxiety, trauma, and also to improve cognitive performance and burnout caused by long hours in a highly stressful situation, for example. So let me show you a little bit what is the experience into one of these recharge rooms. This is one of the experiences that you can choose. You will be seated in a recline chair. There are nature sounds associated to all the experiences, as well as music.
Activate Serenity Beach.
You can choose the biophilic experience that better goes with you, and they are divided by the things that they target. Like they can target relaxation, they can target energy, they can target the mood. So you can just choose from the menu what is that you feel like doing.
Activate Redwood Forest.
You can enter these rooms individually, like by yourself, or even with your teammates. Recommendation is to be 10 to 15 minutes at least inside the room. You can be as long as you want. In silence, just being present. Maybe relax just to talk about the rooms. Okay, so what is that we know about these rooms? We do know that bioexperiential design can enhance recovery of patients, connection between individuals, and well-being. So not only for healthcare workers, but also for families and patients. That's why we have now we're working on a project to try to put all of these rooms together in the ICU setting and in labor and delivery. So in healthcare workers, we do know that they lead to reduction of stress and burnout. The relaxation leads to have fewer medical errors. They can enhance empathy and communication and connection with patients and their family members. So we wrote a paper where we saw that there was in over 100 subjects, healthcare workers that did like a short-term, they experience short-term, they have a short exposure of these environments. They have a significant reduction of the perceived stress levels. So now we are working on a multi-center clinical trial where we are seeing that these rooms, they can be a mental health modulator because they lead to be more calm, more hopeful, and more alert. This paper is modulation, it's on preparation. So some of the statements that they are related to the experience of these recharge rooms are things that make us think that the patient is at awe, right? Like having goosebumps. You are in front of something that is bigger than yourself. Feeling this being connected things, being more together with your colleagues, feeling connected to humanity. It's like feeling more grounded. So I would like to invite you all to participate in this new research study that we are conducting, where we are investigating how to decrease the stress and improve mental health in all the healthcare workers at the Mount Sinai. So everybody can feel recharged, and it can investigate a little bit how the brain signaling changes when entering these kind of rooms, not only for short experiences, but also in a long term. So if you want to participate, please reach out to our coordinator. We'll be happy to have you. So this is my last slide. I really hope that that we'll learn a little bit about what neuromodulation is and how we can use it in our day-to-day practice, or how we can use it to address different research questions that we might have. Thank you for your attention, and let me know if you have any questions.
Thanks, Dr. Cortes. I just had a quick question.